And just of note, we are streaming this live to YouTube on the CT DSS YouTube page.
Thank you. Tiffany, are you able to pop the slides up yet?
Yep, let me go ahead and do that now.
And I think we could jump in, Carson.
Great. Yeah, so I know last time we met, we did go around the room and introduce ourselves. There are any folks who did not were not able to join the meeting last month. I don't know whether we could just, if you want to quickly let us know who you are. If not, that's okay. You can put your name and details about your organization and what you do at your organizations into the chat. That way we can be collecting an understanding of who we're speaking with. That's fine too. So Tiffany, if you want to jump to the next slide, we can just start by looking quickly at what our agenda is for today. We do have an hour and a half time slot scheduled. For those who were here last time, we tried to pack a whole bunch of information into not quite enough time. So we realized that this is in the interest of making sure we have some robust conversation and can really have a dialogue in the context of this meeting. We wanted to extend that time. So thank you all for being able to make the additional half hour work with us. We're going to actually start with a really quick overview of a kind of a roadmap to give you all a sense of where are we in the process of this maternity bundle work and where are we going. So you kind of get the landscape of things, and with some details around some of the next couple of weeks / months of the cadence of when we'll be meeting and who we'll be meeting with. And then we are going to spend a bulk of time today looking at that health equity framework that we breezed through a little bit last time we met. I know we sent out the deck to folks, so not sure if you've had a chance to look at it, but what we're going to do today is really focus on that first section to look at what details we have identified that can help to frame the health equity lens for this project. And would love to really gather as much feedback from the group as possible. And then we'll also look at what the questions are for section 2 and ask for people to let us know whether or not you feel anything is missing. We will do a follow-up looking at the doula integration draft scope from what we talked about last. We spent a bulk of the time last month talking about this piece of the work. So we're going to bring this back after having met with a group to have a kind of focused discussion on the doula integration work. And then we'll just close out quickly with some next steps. So next slide, Tiffany. Okay. So this is just, as I said, just a really high level roadmap, but hopefully gives you guys a better sense of what is the work that's going to be done to really get to that final maternity bundle design, and what is our current plan for when are the different pieces of work going to be focused on. So you can see we're really right at the beginning, looking at that doula integration. We're going to start to move into looking at the blended payment rate details as we come to our next meeting. We're going to, between now and that next meeting, we'll have a focused discussion group. We'll talk about that in a second, to start to really work on starting to define that blended rate. And then from there, we'll be looking at what are the different building blocks that are going to be required, the how, in order to make the bundle viable. And obviously, we need to talk about the services to be included in the bundle, what the quality measures will be, defining the payment methodology, and all of those pieces will lead into that final bundle design. Which, by the way, we're looking for sometime, hopefully around October-ish timeline to be close to having that bundle defined. So next slide, Tiffany. At a more granular level, here is just some dates that you can understand. We wanted to make sure everybody understands that the feedback is going to be gathered in these monthly advisory meetings, but also in ad hoc sessions where necessary, not for every piece of the bundle necessarily, but when appropriate, we'll be scheduling some smaller, more focused conversations to allow for additional feedback and input. It is going to be an iterative process as we go. So we started out last month talking about the doula integration, and we're bringing it back here today after having had a focused discussion with a smaller group of subject matter experts. And so here, each of the design elements is going to be merged together, as I said before, into that maternity bundle design. These are anticipated tentative schedule dates. We will be sending out invites as far in advance as possible, with the understanding that we want to make sure that we're really clear that we're not going to have to reschedule something if we hit a little bump in the road along the way. But our plan is to continue to meet again to talk a little bit more about the doula integration with that smaller group, and then to initiate those provider payment discussions. Aiming for both of those are for kind of early May, to bring something back to this group for our next meeting, which is scheduled right now for the 17th of May. You can see that the June dates are on there as well. We will do our best to give you as much lead time as possible, understanding that as we come into summer, people start to take vacations and timelines are a little bit tougher. Okay, so that's kind of our overview of the roadmap and what to expect. Before I dive into talking about the health equity, is there anything else that other folks want to add from the Connecticut team, or any questions that the group has?
It maybe just briefly, and I wanted to say, I think one of the reasons that you all are here really help provide feedback and guidance. So if there's questions that come up, we really value all of your various roles and expertises, from people who have been our members to those who are advocates to those who are working in this area and are providing services. So all of your expertise and backgrounds and lived experience are really valuable. So anything that you'd like to share as part of this, we welcome that. And we really look to you to provide us input as we move through this process of launching this maternity bundle. So very much look to all of you. So feel free to raise your hands, ask questions. We really do want to hear from you as part of this, and hopefully the extra time we've allocated today will allow for some of that. And the only other thing I wanted to mention, as I know there is a request for potentially interpretation services, and we just unfortunately don't have the funding available at this time for that. However, through YouTube, you can actually turn on closed caption in Spanish language, which is, I know, not ideal, but is kind of the only solution we have at this moment. So I just want to also make a note of that. So thank you, Carson, for the opportunity to interject.
Sure. Thanks, Brad. The other thing I forgot to note, that you can see there's a note on the bottom here. We did send out an email a while back asking for people who wanted to be involved in those smaller focus discussions to reach out. So with the provider payment discussion coming in the next several weeks, if you have not already let Fatmata know that you're interested in being included in that discussion, please do reach out to her. Her email address is there, and this deck, you all should have a copy of this deck, so you can find it there as well. Okay, great. So let's move on to check in about the health equity. As I mentioned, we have the three sections that we went through last time. The first section is intended to really gather information about in this case, the maternity bundle design as a whole, with the second section being about each of the different design elements. So it will be, the questions there will be answered based on doula integration, the blended payment rates, et cetera. And then that third section, which we really aren't going to spend too much time on right now, because the third section is about once the program is implemented, it's a looking at how well is it working? Are there things that need to be updated? Were there things that maybe weren't considered but need to be considered now? So obviously it would be a little premature for us to be able to really answer those questions when we're not quite at implementation yet. So I do want to focus today on that first section. So thinking about the maternity bundle as a whole. What you see here is not the questions that we asked. You all had those to take a look at, but really kind of when we think about what are the program goals and the intended populations for impact, what the team has come up with for the responses to that. For the program goals, the team has identified that their focus really should be on the reduction of certain rates specific to NICU utilization, overall C-section, as well as NTSV C-section, the NAS rates, and then adverse maternal outcomes. And that the idea is to approach this by developing services that will be able to close the racial disparity gaps in maternal health and birth outcomes, creating a parity between OBs and midwives, and really importantly, including services such as doula services, community health workers, and other supports, knowing that those are critical to closing the gaps where we have them. Certainly improving patient experience of care, aligning payment models across both Medicaid and the state employee health plan, and then aligning quality measures. And we are actually right now in the process of assessing the baseline data to be able to understand, okay, where are we starting from? And then developing the targets and goals for how over the next few years, how the expectation for the gaps to be closed. The intended population that we're really wanting to focus on are obviously the Connecticut Husky birthing people, but really specifically focusing on birthing people of color, and including all eligible populations in the bundle program, with a focus on aligning clinical and financial incentives. So I don't intend to be just presenting to you all today. This is really intended to be a robust conversation. So I will open the floor to folks, whether it's from the DSS team or other questions, comments that folks might have. Amy, I see your hand up. Oh, you're on mute, I think. The dreaded mute.
Thank you. In the area where we have include access to doula services, community health workers, and other support, did that originally specifically say lactation services, and now it's under other supports?
I think it might have. Angela, I don't know if you can speak to that more specifically.
I know we added the lactation supports as a specific subtype that would be included within the bundle itself. It's certainly that goal is certainly intended to capture lactation. So if it's helpful to call that out.
Yeah, I asked because the lactation piece was vetted, and I would regret to see it removed as something as a more of a primary support service.
Okay, that's helpful. Thank you. We will look to be more specific if it makes more sense. We can, these are high level, but it's important for us to make sure that we don't miss the details within. Dr. Magros, I see you have your hand up, please.
Yeah, just a quick question. I see NAS on there, and CHN just recently did a study on NAS, and one of the points of confusion that came up as we looked at the results, most folks use NAS to refer to abstinence from opioids, but we learned that CMS has a bit broader definition, and they were looking at things like fetal alcohol syndrome as well. So I don't know if the focus here is just to look at, abstinence from opioids. We might want to be a little more specific in calling out what we're focusing on.
I think that's really helpful. I would also, I don't know sorry, go ahead, Angela.
No, I would say welcome input from the group as to whether it's more impactful to focus on the opioid specific version of the neonatal abstinence measure or a broader definition. I believe the data that we can confirm this with you, Dr. Magros. I think the data we received is specific to opioid at this point. So if we as a group decide it's important to go broader and look at alcohol and other drugs as well, we just want to make sure we match the Connecticut baseline data to that definition.
Yeah, agreed. Okay, thank you. Dr. T, I see your hand is up.
Yeah, good morning. I just wanted to reiterate the importance of including the breastfeeding into this bundle. It's really the first opportunity we would have to actually add a preventative care component to this bundle and really move the needle on the population health of this group of neonates that's going to be born under this bundle moving forward. And it's really the right time. Before mom delivers is when she needs to hear about breastfeeding. So to drop it would be a terrible loss.
I'll just, I don't think there's any, oh, go ahead.
No, please, Brad.
I was just saying, yeah, there's no plan on dropping it. We definitely are, it's definitely part of the bundle component. I think probably just need to update our wording on how we're including it here, but we're definitely planning on having breastfeeding as part of the bundle support, and specifically adding resources for both doulas and breastfeeding support services as part of this, which we've secured for the first phase of the bundle launch.
Wholeheartedly agree. It's in all of the detail around the covered services component. We can make sure we elevate it into the goal language too.
Great, thank you. Karen, I see you have your hand up.
Yeah, I just wanted to ask a follow-up question on what Dr. Richards just said. That I know that the Hispanic Health Council had done a fair amount of research to provide an evidence base behind a lactation support option that is CHW based, and I wanted to make sure that that also was included. That had been in kind of early discussions.
Yeah, I'll just say that there would be no limit. So in terms of the function of the bundle and what we're including is just as kind of, and I know we've gone over this only a few times, so it can be a little confusing to remember what actually we're including and not including sometimes in the upfront kind of payment to providers, but the plan would be to include in that plan prospective payment. So kind of upfront payment would be doula support services as well as lactation support services. And so there would be some flexibility of what type of model would be able to be provided. There's nothing that would prohibit that community health worker model from being utilized as one of the models for lactation support services. It would really be kind of providers having some flexibility. And I know Dr. Tremlock and we had a conversation about like, are there some guidance? Is there some guidance in terms of what constitutes effective breastfeeding support services? But from our framework and our understanding, that specific model with CHWs would definitely fall within the scope of something we would be interested in seeing rolled out, again, without being overly prescriptive to providers as to what that looks like. But there would be no reason not to include that as part of this. Again, we wouldn't necessarily be paying directly to those programs, but it would be incorporated in terms of funding, and we'd be looking towards likely outcomes in terms of how many people are breastfeeding, or how, because obviously that's in the end we want, and I think we all probably are looking at those goals of like, are people getting the services they need? Are more people breastfeeding? How do we document that? And so we'll be looking to some of you to get more input on that as we move through this.
Great, thank you. Sorry, Karen, did you have a follow-up?
No, I was just saying thank you.
Okay, great. Cynthia, I'll go to you, and then I see that there is a question in the chat, so I'll get to that after Cynthia's question.
Good morning. I just want to follow up to this conversation that we're having regarding lactation support, and just say I agree with everyone saying that this very much has to be a part of the conversation, and we have to prepare for that. But also bearing in mind too that the doulas, and I know more specifically a lot of the doulas here in Connecticut, if they are not CLCs, we are planning for them to become certified lactation counselors, and they've had a lot of training as well. But also to refer to the research and the work that's being done presently to show that if there are very good labor and delivery outcomes, very good birth outcomes, then chances are there's going to be more of a likelihood that there'll be successful breastfeeding. So not that we want to cut anybody out. I'm sure that we could all work together in trying to figure out how we're going to make sure that there is this support for lactation, but just bearing in mind that it all kind of works together. So, I just want to say that I just don't want it to be, all fragmented. It's all working together. And that's all I have to say about it.
Great. Thank you, Cynthia. That's really helpful. In the chat, and then Amy, I'll come back to you for after I cover this. So the question is from Allison about with multiple labor and delivery units closing in Connecticut, is there's something that the maternity care bundle may be looking at. Looks like Windham County now has the highest preterm birth rate as a county in the state at 10.8%, and was one of the areas that saw a labor and delivery closure. So that is a really excellent question. I would look to the Connecticut team to help.
Yeah, I mean, I think that's something that's obviously important in terms of access to services. However, I wouldn't say it's necessarily something that DSS we oversee in terms of, is there a labor and delivery unit in that specific area? But obviously that is important and that this could impact that, but it wouldn't necessarily be a part of the oversight and rollout of this bundle, but acknowledge that having access to high quality labor and delivery services is a really important part of making sure that people, that especially Medicaid members, are getting effective, and safe delivery care in the antenatal period.
Brad, if it's okay if I just add to that there are some pilot sites across the state that are doing mobile care, and that might be something worth looking at when the provider payment options get looked at within this group. I'm not quite sure what the reimbursement rates are for mobile perinatal and postpartum care. I'm sure there are people on this call that do, but just thinking through that, if that is not something that is already covered in some capacity, that maybe that's something that could be taken a look at.
Great. Thank you, Allison. Amy, please.
And I think I'm just going to send a message out rather than keeping the conversation on the lactation piece. We're moving forward, and that's a good thing.
It is, yes. And it sounds like everybody's on the same page about being clear that the lactation is not only really important, but for sure something that plans to be included in the bundle as well. Sorry, go ahead.
There's also a question in the chat about adding increasing rates of breastfeeding into the program goals. So we can certainly consider that as well. And I know that it will come up again when we talk about the quality measures for this program too.
Great. Okay, so IPV, so I just saw another question. Can we also consider increasing IPV education and resources?
Yeah, I think one of the things that as the bundle is, what are some of the program, what are some of the quality measures, and is that something that we want to prioritize as part of this? Obviously a really important part, especially around potential, I think, maternal mortality rates and gun violence is a concern. I think, again, we should maybe revisit as part of that as welcome that type of input and framework. So what are we trying to drive towards? And maybe maternal mortality or adverse outcomes are related. I think one of our questions is obviously making sure we have enough focused measures so that we're getting the outcomes we're looking for, but not making it overwhelming. So there's so many measures. And so getting that balance right is going to be an important part of this, acknowledging that IPV is an important aspect of care for pregnant individuals.
Great. Okay, that was really great conversation and feedback. So why don't we head to the next slide, where we want to really focus on thinking about the community context in which this work is being done. And at a high level, we want to make sure that we're looking at the negative impacts on the affected communities, what those are, what the data can help to provide in terms of details around the current context. And then also looking at what are some of the barriers or challenges that might already be in place or arise as part of this work, and thinking about what are some of the ways in which we could mitigate those strategies trying to think through that now rather than waiting until that barrier or challenges arises and then figuring out what to do. So just briefly running through, looking at what those negative impacts are, what the group identified were this, obviously the persistent systemic racism that's negatively impacting the maternal and infant outcomes. COVID-19 has also really had a tremendous impact here and disproportionately on Black women and birthing people of for multiple reasons. Also a lack of trust in the healthcare system, both based on historical and current discrimination, whether it be implicit or overt. All of these things are what are leading to have had negative impacts on the outcomes for these different measures. In terms of what we're finding, just at the baseline, as I said, we're looking at the data now, but just at a high level, here's some of the pieces on the right-hand side here. Over the past 5 years, NICU utilization rates have risen by 2%, and adverse maternal outcome rates have also risen by 4%. And within that, we're seeing that Black and African-American members have the highest rates of NICU utilization, C-section, and adverse maternal outcome, with a 3% higher C-section rate than white individuals, and a 6% higher rate of adverse maternal outcomes than white individuals. So obviously the data is showing what everybody already understands, but I'll take a pause here to gather feedback from the group or conversation from the group about, are there other additional impacts that we haven't identified here, but you think are really important to keep a lens on as the work moves forward? I see somebody in the chat. Karen, please go ahead.
Yeah, I apologize if I missed this, but what I don't see captured here is that systemic racism also leads to higher negative social determinants of health. And so I think, understanding that not all of this will be possible in the first iteration of the bundle, I think working towards a system where Medicaid is reimbursing community-based supports to address those social determinants will be really important in addressing disparities.
That's really helpful and for sure something to be added. Cynthia.
Yes, another concern would be the increase in induction rates. They have been, it seems like every single person that we're talking to is getting information, especially pertaining to Black and Puerto Rican families. There is this conversation of, yep, this is what we're going to do. We're going to induce you. And that's something that we really need to look at, because the induction often lead to those C-section rates that we're trying to decrease.
That's really helpful. I don't know, and I'm not sure whether somebody on this call would have the answer right now, what the data is that we have around that, if we have data that helps us understand that.
I was just going to say, I think Dr. McGraw's on, but I don't think we actually, unfortunately, have this information easily at hand, which is an issue that we face in terms of some of the data that in holding people and looking to hold folks accountable, and also measurement, that I think induction rates are not something that we easily capture. But Dr. McGraw, do you want to jump in just to confirm that?
No, that's true, Brad. We haven't looked at it, and we would have to go back and do like a check of the data on the claims and see if we're actually getting those line items on the claims, knowing that it might be present in some and not in others, depending on the coding accuracy. So that might be a problem with the data.
Yeah. So definitely something for us to take back and take a look at it. It certainly is makes sense to be looking at it with the context of the higher rates of induction tend to lead to a higher rate of C-section. Obviously, it's an important piece of that detail. Thank you. Sorry, go ahead.
No, Cassie, I just wanted to add quickly. Yeah, I know that we don't really capture that, but what's consistent with what Cynthia said is the fact that you have a high rate of Black and Puerto Rican families or Black people being induced, and definitely the disparity shows though in our C-section data. So it is something that we should consider looking as we move forward.
Absolutely, yeah. Great, and I think somebody had their hand up a second ago, but maybe changed their mind.
Dr. Kanti?
Yes, hi, sorry, I'm having some difficulty with my internet.
Okay.
I just, and I'll put it in the chat if I get cut off. But
Okay.
I think another piece is to, sorry, I'm having trouble. Just put it in the chat.
Perfect. Yeah. If you want to put it in the chat, then I can take a look at it and we can address the question. In the meantime, any other thoughts, questions, feedback? The other piece that we could move to on this slide that we haven't talked about that is doesn't have a lot represented right now, but I imagine could use more is what are some of the barriers and challenges that we may expect as the work progresses. What we've identified here is that member engagement has historically been a challenge. And one of the strategies that we've engaged here is to include Husky Health members with lived birth experience in the design process. So folks are invited to this advisory group and also looking to include them in those some of those smaller discussions. But thoughts about additional barriers or challenges that might crop up as the work is implemented.
Carson, Hope and Dr. Kanti just added some information in the chart.
Yes, okay. Dental lens. So looks like with the dental lens, perhaps look at access to dental care and utilization to see if there's a high concern in delivery with a negative impact. Okay, I don't know if there's a thought from the group around whether we have data there or the connection.
Yeah, definitely an important part, and we definitely would have data for dental connection. I think again, one of the things is thinking about what our measures are and how we're what we're holding people accountable to. Obviously, dental care very important. I think as a preventive measure as well. So something we can put on our list to follow up on. And I think Dr. Kanti had mentioned measuring the experience of care for Black women, and I'll just make a note that something that we are very interested in is Fatmata and I have talked extensively about trying to make sure we're capturing the care of individuals, especially Black women, and their care experience and experience of discrimination. And we've met even with DPH to see some of the data they've been collecting through their PRAMS data. There's going to definitely be some challenges with us doing that, but we are very interested in continuing to identify what opportunities we will have to both capture that data and then actually hold people and providers and others accountable for the care experience that they receive as thinking through the health equity lens. So just of note, that is definitely something Dr. Kanti brought up that we are, I think, very interested in continuing to explore.
Yeah. Great. Lakeisha, I see you have your hand up.
Hi, yeah, so I was just gonna agree with Dr. Kanti and the comment that Karen had put in the chat. The stigma around patients with Medicaid is so high and within the practice role. And like you said, Brad, we definitely need to look at that, because on a practice level, I know for a fact when it's known that a patient has Medicaid, it's instant bias, instant. And the care that's provided is definitely different, and it is surrounded by that bias. So, and then that turns into the patient's experience with her care. So that's something that definitely needs to be looked at and considered and thought about.
Yeah, I think I'll just add to that, Lakeisha, Dr. Kanti, Karen, like Brad said, that's something that's really just very important to us in terms of capturing patient experiences, especially the experiences of, Black women and birthing people and people of color because they've been experiencing adverse outcomes. We've brainstormed, some ideas that we don't even know whether it's something we can do, but just so you all are aware that it's right at the forefront of our minds, and it's something we're going to keep working at until we're able to actually implement it.
Great. Thank you. That's really helpful. Any other thoughts, feedback, questions before we move to the next slide? Okay. Great. Yeah, Tiffany, if we want to go to the next slide. So the last section of the health equity framework in section 1 is looking at a couple of different things. The first being around community engagement. So we talked about community context, but we also want to think about how are we actually engaging with the community to make sure that we have all the different voices heard from the folks who are actually receiving the care and involved in providing the care. Obviously, this discussion today is one piece of that. And then the other pieces, as we've talked about a little bit already, is looking at the data analysis and measurements, because obviously it's really important to make sure that we're understanding what do we want to measure and then how can we measure it. But thinking first about who should be included from the community, the groups that have been identified through our work are the community organizations, such as the doula organizations, Black, Indigenous, and people of color advocates, as well as queer and trans people of color advocates, Husky Health members, as we mentioned before, wanting to make sure that we're focusing on the representation of marginalized and underserved populations. And then there are some additional organizations to help that DSS engage, which include CHN and the Connecticut Health Foundation. So thoughts from the group around, are there any organizations you think who are not represented here who should be, or additional specifics? Karen, I see you've got your hand up, please.
Yeah, I'm just thinking about immigrant rights activists, particularly with the inclusion of undocumented pregnant people in Medicaid services. I think that'll be especially important.
That's really helpful. Thank you. Other thoughts?
I was going to, and I'm sorry because I missed the first part. I left my car, matched into my car. Are you talking about other groups that just need to take part in the planning and the conversation that we're having? Is that the question? I'm sorry.
Exactly. No, that's fine. That's exactly, we're wanting to understand, okay. Make sure we're including the right people. So if you're missing anybody here.
Yes. Yeah. Certainly. I would say that those organizations that have been working closely concerning doula integration and working in the community, like Bridgeport Prospers, through United Way, like New Haven Healthy Start, because they have been utilizing and supporting doula programs very successfully. So I think that they have a lot of input, the executive directors, especially of those programs.
Great, that's really helpful. Thank you. I should also have said at the outset here, I know Brad had mentioned, please, we want all the feedback and questions and thoughts to come in. And if you have any after we close out a little bit today, please don't hesitate to send further things to us, because we don't want you to think, oh, well, this is your only opportunity. It isn't. And I know I can speak from my own experience that I often think of things after the fact and wish I had said them, but didn't think of them at the time. Please don't hesitate to reach out to us.
And I saw one, I just wanted to, Shelley had mentioned the stigma of substance use, particularly during the perinatal period, which I just wanted to highlight, thinking very, very specifically about that, the folks with substance use disorders and actually currently paying for those services outside of the bundle, at least initially. And I'll just, as an aside, quickly say the reason for that is we recognize not all providers at this time incorporate behavioral health and substance use disorder treatment into their practice. But in the long run, we'd love to see that incorporated, but recognizing we want people to get access to those services that exist in the community. And so that's the reason we're excluding that, but not, we will continue to pay for it, but just outside of the bundle, more for practical purposes, but we're very committed to seeing increased rates of substance use disorder treatment, especially with medication-assisted treatment as appropriate for opioid use disorder.
Great, thanks, Brad. And Shelley, I see your hand is up. I'm not sure if you wanted to add anything more or had another question.
Yeah, I did. I just wanted to add to that in speaking alongside what was just said. I think having a representative from the behavioral health umbrella be part of some of that might be a valued perspective, particularly around the substance use issue. I think we've seen some fairly good saturation of screening around postpartum depression and anxiety, but I do think that we still don't see full saturation around substance use screening, and know there is disproportion around how that screening and testing is done. And so I think including that voice in the community engagement process would be important.
Great, thank you. I also see that Lucinda also suggested the Black Nurses Association and Hispanic Nurses Association, which I think really helpful lens as well as we think about nurses both within practices and hospitals as well. In terms of the feedback and communication plan, you guys have experienced some of that already. That's really the idea of this work, is to have a design phase that's going to include several meetings to allow for this iterative process. So engaging with this group is part of that. Having those ad hoc discussions, as we've already held around the doula integration, and we're planning to hold around the payment modeling. And then also DSS engagement with CHN and Connecticut Health Foundation to help us reach the communities and the members that are not otherwise represented, as kind of a support in identifying on the left who are the different communities and organizations, and the feedback you all have provided. We're looking for ways to be able to really connect, once we identify the who, how to connect with them. And certainly would ask for help from you all if there are organizations that we struggle, that we're having a hard time finding a way to get to, or specific members. The last, yeah, please.
Sorry, Cassie. No, I'm sorry to cut you off, but I just noticed that Lakeisha still has her hands up, or is it a legacy?
No, I'm good. Thank you.
Okay, thanks.
I missed it. It was hiding in the picture behind you. Okay, thank you. So the other piece here is that data analysis, as we've been talking about kind of throughout the discussion. And as we mentioned at the outset, where we are currently collecting data that we know we have, it's around the NICU utilization, the C-section rates, including the NTSB C-section, the NAS rates, which I know we need to work on being a little more clear about what exactly we mean when we say that. And also the adverse maternal outcomes. In addition to that, DSS is going to be working with Yale Core to identify and collect additional data related to health disparities. So a couple of suggestions came up today that I think we probably want to dig into a little more to see, maybe we're not collecting some data today, but can we start to collect that, and how best can we do that? In terms of the stratification of the data, it's currently stratified by race and ethnicity. And DSS and CHN we're looking to assess the availability and capability of stratifying by language and disability if appropriate. And also strategizing about how to collect patient experience data via CHAPS, I can't say it right. Anyway, you can see it there, and or the PROMS data. But thoughts about, suggestions about maybe how to collect some data that you all might have, or the best way to look at certain data? It's okay if not. I think we've gathered a lot of details, and actually I'm just realizing there's some folks in the chat. Okay, I see some people are giving some other suggestions about Ministerial Health Fellowship now works with both doulas and CHWs if not looped in. So that's great. Thank you, Karen. And Karen, I see you have your hand up, please.
I was just going to say that in terms of data and analysis, and I know this is something DSS is already thinking about from other conversations, but looking at disproportionality rather than just disparities can be really helpful in moving the needle on equity.
Yeah, absolutely. That's
when you'll see that when we come back with the data analysis of baseline trends and future targets, our goal is to look at the disproportionality as well and to try to set overall targets for overall reductions in NICU, C-section, NAS, and adverse maternal outcomes, but then also to set specific gap closure targets as well, so that the target improvement for Black populations would be higher than the target improvement for other populations.
okay. And then I see there was also a suggestion, Lucinda. Thank you. That's helpful to understand. And we might dig in a little bit more around understanding what's being collected there. That's really helpful. Thank you. Okay, so in the last few minutes of looking at this health equity framework, I wanted to just review in section 2, what are the actual questions that we've identified as the questions to be answered to keep that health equity framework. And again, these are the template questions, so they'd be asked of each section, but we would be expecting to fill out each of the answers or provide answers to each of these questions based on each specific piece of design. So as we look at the doula integration, we would answer the questions specific to that piece of design. There will likely be overlap in answers from different pieces of the design, but probably some differences. And just wanted to review what each of these are with you all and ask if there's anything else you think should be considered when wanting to focus on the health equity for each piece of design. So we've got it broken out similarly in goals, community engagement, community context, data analysis, and measurement. So around goals, it's just the proposal of what are the expected results and outcomes of the design element. Also around equity, how does the proposed design element impact existing inequities, and how does the proposed design element align with the overall goals of the project to make sure that, at the highest level, we're driving towards what the group has identified as the goals. With the community context, it'll be similar around to what we talked about in section 1 around the potential barriers, challenges, or risks that could limit the ability of the program to be able to really achieve its intended outcomes. And what are the mitigation strategies? So while it's really the same set of questions as in part 1, it's with a very focused lens on each specific piece of design. Again, community engagement, the answer may be the same here as it is in section 1, but we also want to make sure that if there are unique populations or folks who need to be represented in each piece of design, that we're not missing that. And then again, with data analysis and measurement, are there more specific pieces of data that we should be looking at in regards to one specific piece of design that maybe isn't at the overall maternity bundle level? So that's at a high level. I don't know if anybody has any just kind of gut reactions in the moment. You can absolutely take it back and think about it a little bit, and let us know if there's anything more you would like to, or you think should be included here. Okay. Sorry, go ahead, Angela.
No, and I think you said this, Carson, but just to reiterate, we're anticipating going through this exercise as pre-work to each of the specific topics that we'll cover over the course of the next several months to make sure that there's real intentionality behind applying the equity lens to each of the design elements. So, sort of welcome feedback on the structure now. When we next come together, we'll have populated this as pre-work to our discussions, and we'll have an opportunity to give us feedback in the future at any point really in the process if we need to update or amend the structure.
Yeah, absolutely. Okay, so Angela, I will actually pass it over to you to take the next piece of work.
Oops, sorry. Thanks, Carson. So today, the other topic we wanted to get your feedback on is our overall approach to doula integration. And a subset of this group and some other community members got together, I think it was just last week, and had a pretty robust discussion on an initial draft of how DSS could approach doula integration. That feedback is, we took that feedback and aimed to incorporate it and reflect it in this updated version. So if this is the second time you're seeing a slide like this, know that we did aim to incorporate and hear your feedback. For overall doula integration, I think just as a reminder, when we met last time, we talked about how the overall maternity bundle launch is the long game and the ultimate goal of this advisory process and of what DSS wants to launch. There are at least 2 interim steps that we're looking to do prior to and or concurrent with the overall doula, the overall maternity bundle payment program. One of those is provide support for doula integration. The other is establishing a blended case rate. So that blended case rate is a topic we'll cover at future sessions. So for today, we're looking at how can we support doula integration leading up to the overall launch of the maternity bundle, where it would be wholly integrated within the bundle. So DSS is envisioning a process where some funding is made available for an initial investment in doulas prior to the maternity bundle go live, where the objective of that funding would be to establish partnerships between doula providers and OBGYN midwife practices and build a foundation so that the doula integration is ultimately sustainable as it moves into the maternity bundle program. The scope of work that we would be looking at to achieve those objectives include an assessment of current doula capacity, including their structure, workflows, barriers, et cetera, within Connecticut, and what can be used to facilitate partnerships and capacity building for doulas. I think we heard from the group last week that including providers and hospitals in the assessment process would be important, and making sure that they are aware of and understand their obligations in the context of achieving success in a doula integration model through the bundled payment program. Ideally, we would also have some workflows and business processes that are documented between doulas and OBGYN providers prior to the bundle launch, and that the work coming out of this pre-bundle effort would result in recommendations and feedback and perhaps a presentation or engagement of this group. For the funding, eligible entities would be Connecticut-based doula organizations or collaboratives that have a local presence, and that would include any regional or local hubs that support individual licensed doulas, and ideally is focused on entities that work to advance health equity and reproductive justice. The timeframe of the work would be late this year into the first half of next year. I think we heard from the group initially that timeframe is likely too short and that there will be a longer tail, and DSS is open to that possibility and will evaluate the need to extend sort of additional funding or a time frame for the work once it's underway. And then the concept of funding one or more organizations was also a topic of discussion, where DSS is looking at anywhere from funding one organization that could broadly support doulas across the state for this capacity building work, to option 2 as funding 3 to 5 organizations that would support doulas in their respective geographies or specialties. And the third option would be to carve money into small capacity building grants that would go to as many doula entities as possible. And I think we heard from the group last time that somewhere between option 2 and option 3 would be preferable, with a recognition that consolidating funding comes with the value add of being able to build the infrastructure that would create sustainable programs longer term. So let me pause there and just open it up for any questions on the concept or feedback from the group on direction and the proposal. Dr. T?
I guess I'll just ask the question is it going to be limited to doula integration, or would this be the model for opening up to other components of the bundle that we've talked about? Why did we select doulas to move forward with as opposed to other parts of the bundle that we talked about previously, I guess is the question.
Yeah, I think I'm happy to help answer that. I think we've heard pretty clearly from some of the engagement that DSS has done that integrating doulas may be a slightly heavier lift given the historical relationship between doulas and maybe traditional providers in this space, acknowledging that some providers both doulas and historical, I think maternal health providers are ready to do this already. But I think we see this as an integral part of the program. Not that other parts are not integral, including breastfeeding support and others, but recognize there may be more friction in this area in terms of establishing relationships between some of the doula providers as well as the historical maternal health providers in this space. And so we're really looking to help facilitate those connections in ways that maybe historically have not been done. And so that's really kind of the background as to, and the reasoning behind it. And we've had, like I said, have had some engagement with doula groups, including through DPH and others that, have helped shape this. And I don't know if you want to add anything else. I know you have a background in this as well.
No, Brad, I think you summed it up pretty well. We looked at the historical relationship between doulas and other care providers, and we felt that the heavy lift will be on integrating this particular aspect into the bundle. And breastfeeding supports to a certain extent we've covered, but we've never called it out in our services. So that's something that maybe to a certain extent providers are already doing. It's just that we want to focus on that aspect as well. But I think you summed it up well.
Amy?
Yeah, I have a few comments and one quick question. The quick question, and I think it's maybe just a typo. I noticed that you have licensed doulas. I think you might mean certified doulas. And I have a few comments. I agree that it is a heavy lift integrating the doulas into the existing maternal child health healthcare system, i.e. providers. And so I really do support that we have to do this heavy lift now we have to do everything we can to get this integrated. I know just in my own experience, I oversee a prenatal and postpartum clinic at an FQHC, and there has been some subtle on the surface, oh yeah, bring the doulas on, but there has been some subtle resistance, and it's really not understanding, I don't think, the role and the right of the doula to work, in her capacity with the mother, sharing information in a way that does not have to be approved first by the provider. So there's that piece there. So I think this is important to do the heavy lift because the providers could be a barrier. And I think we have to seriously look at that. And the other thing is, I just have concern. I think it's smart to, option 2 or 3 makes a lot of sense. But I'm concerned about moving forward, and I shouldn't be looking forward, I guess, because we're working here right now. But how do we move a service like doulas out of the grant-funded capacity, whether it's privately funded or state-funded? How do we move it into a real integration where there is some type of third-party reimbursement for the services, which would allow mothers to have the option to choose who they want, and also the doulas to work more independently? That's it.
Thank you. I'll just say, as part of kind of the strategic decision, as part of our prior design is there will be dollars allocated for doula specifically as part of the bundle. So, I don't believe other payers will necessarily be doing that up front. And so we recognize that's challenging, but we will be looking to do that as part of the maternity bundle through DSS.
Thank you. I think Dr. T, was that a legacy hand, or do you have another comment to jump in?
No, it's a legacy hand. I apologize.
No problem. Then Chris.
Yeah, hey, Chris Morosky. I agree with Dr. Trimberlake and Amy very much. And the statement I think that was earlier made in that engaging the providers as well as the hospitals with this is going to be very important. We here at UConn are already starting to have some conversations about this. Got very excited about doula coverage and what's coming. And hospitals have their own rules, regulations, and many, I get very excited about initiatives here at UConn, and then I meet the regulations of hospitals. And we need to make sure that this is done with all parties really involved and as part of the conversation, I think, to make this be successful. So it's certainly with work groups or further conversations, I would recommend engaging hospitals, hospital administration, as well as the various different providers in the state as we try to work towards what sounds really beneficial to patients. And the other component of it, which is beneficial to patients, is to think about this as prenatal, hospital, and postpartum, and not just be talking about like labor or birth support doulas, but what all the different services that doulas possibly could provide to our patients. Thank you.
Thank you. Others have feedback or input on the approach to doula integration? Right. Oh, Dr. T?
Yeah, I'll jump in, I guess, as one of the hospital and providers here, representatives here. I think that a very clear path for getting at exactly what was said earlier, where it's easy for me as either the chairman of the department or as the lead physician in my practice to identify these folks to bring in. I don't see this model much different than the work that we've been doing with breastfeeding. It's how can I get them in to my system and not chip away at the DRG that's available to cover the services that I offer, right? So if you're going to create a very clear pathway, or we're going to create a very clear pathway here for that to happen, this lift will get incredibly light, because I have great interest in having additional coaches in my mom's rooms on labor and delivery. It's just that I can't necessarily offer them currently because they chip away at the DRG, and the guys that are counting the beans at the top of the hill get really upset with me when those numbers don't come out right. So if you're going to provide me with an avenue for that, it's going to be very easy for St. Francis, for Trinity, for example, to join forces with one of these organizations and put a doula in every room for our Husky patients, no problem.
Appreciate that. And I think, we're going to be looking for champions to help sort out, what are best practices in this space for working together for doulas and traditional providers, what kind of arrangements can be set up for this to be facilitated so that it's easy for everybody, not just for those who are, I think, super excited. And I think Dr. Tremblack, I think we're so excited that you're excited to have doulas on board. And I hope that we'll have a lot more providers, traditional providers in this space, that are also excited. But we also want to make sure we grease the wheel, so to speak, to make it easy for everybody and kind of set expectations both on the doula side and also on the traditional provider side, so that there's some guardrails that are developed together, if that makes sense, so that we can make it easy and we can make this work for everybody.
All right. So as always, if you have thoughts or feedback following this meeting, don't hesitate to reach out. And I think we can go to the next slide.
Yeah, so thanks, Angela. So we just wanted to go through kind of what to expect, what are the next steps, and in the plan for future advisory meetings. So the immediate next steps are that we'll integrate the feedback from today's discussion, which was incredibly helpful, both in terms of the health equity tool and the doula integration design. We do have a plan to meet again with that doula integration group to have another focused discussion. And we'll be bringing back the health equity framework with with that section 2 responses completed to review with them. And as mentioned at the outset of the meeting, we are going to be meeting with the provider payment group. So as just another plug, if you're interested in being involved in that focused discussion, please do reach out to Fatmata so we can be sure to include you in the invite. On the left at the bottom is just what are the coming meetings. It should correlate with that first slide that you saw. So not necessarily the dates here, but the months in which we're planning to have each of the pieces of the conversation. And then more specifically, as we start to look toward the conversation in May around the blended case rate, we just have a couple of bullets here about what is the blended case rate. So what are we going to be talking about and working on? And those bullets are here around doing a blended case rate for the professional fees in order to work on creating a single rate for delivery, whether vaginal or C-section. Providing a financial disincentive for cesarean by implementing a consistent reimbursement rate for vaginal and cesarean. So kind of taking that, what seems like it might be encouragement to potentially perform a cesarean in instances where it's not necessary, to try and even that playing field a little bit more. Looking at the methodology that multiplies the target percentage of utilization for each type of delivery by the original reimbursement rate to obtain one weighted average, typically covering just labor and delivery through, though it could explore examples or designs that could be broader to better leverage the Connecticut starting point, and then allowing providers to test episode-based payments before implementing accountability for care across providers. So that's less of a here's what the plan is, and more of a here's kind of the considerations that will be discussed as we move forward. And again, very much looking forward to having those folks who want to be included in those further conversations to please be included. And I see a couple of folks in the chat. Okay, these are great. So it'd be helpful to have more OBs present. And I see a couple of folks who are volunteering here. So we'll add you all to the list, as well as some midwives be present to represent hospital-based. Okay, great. Any final thoughts from the DSS group or anybody else before we give you guys maybe back a few minutes of your day?
Just wanted to clarify, just based off those comments, just to say like kind of the dual integration, what's labeled here is really just framing how we're going to have the conversation, if that makes sense. So it's really a preamble to the subsequent conversations where we will be looking to really the individuals that are going to be getting engaged to help us think through some of these processes and do some needs assessment, et cetera. And so that's really that subgroup is doing initially, is really framing a future conversation that will hopefully be ongoing later this year, if that makes sense. So there'll be opportunities to engage further in that subsequent work. This is really getting us ready to do that work, if that makes sense. So just wanted to clarify that.
Thank you.
And I just wanted to again say thank you to Dr. T, Dr. Tremblay. Please feel free to jump in if you'd like to.
Yeah, I guess my one thought on having gone through this meeting is that particularly with the doula steps, documenting the process, I think, is going to be incredibly important. I see a lot of parallels in some of the other components that, so if you guys do a good job of documenting the process with the doula integration, things like breastfeeding and some of the other integrative steps or other integrated products will probably move much more smoothly, because CHWs, breastfeeding peers, doulas, I think look very similar to me as the guy who's looking to add value to my delivery equation when it comes to the hospital side or the department side. So keep track of that process, because I think it will make the rest much easier.
Thank you. And I think just one final thing from at least from DSS Managed, again, this group here is really the advisory council trying to represent a broad swath of various individuals who have interest in this area. And so we really appreciate your time and lending your expertise to this process, because it's extremely valuable for us to get feedback as we're moving through this. And so just thank you all for participating. And we'll be, again, the goal with this group is really high level, like touch on things. We're going to want to continue to move forward with engagement over time, where we bring things back from our subgroups at times, as well as other information. So we can feed that to you and get feedback to DSS and us as a whole. So just wanted to kind of reiterate that, and also thank you all for your willingness to engage with us. And also thank you to the Faulkner team for helping pull all this together and for the facilitation.
Absolutely. Thank you all. Have a great afternoon. You have about 15 minutes back of your time. Hopefully you can get stuff done.